Good morning.
สวัสดีครับ
As we're about to begin, please find your seats and make yourself comfortable.
And may I kindly request you to switch your mobile phones and smartphone to silent mode in order to avoid interruptions.
And unfortunately, we have a fire emergency evacuation rehearsal today. So if you hear any fire alarms, please do not be afraid. It's just a rehearsal.
But if there is a real fire going on, I'll let you know first,
We'll
okay?
let you know, okay?
So to your information, the toilets is at the back of this hall is the big one here. You just walk out at the back door. The front door will be locked to avoid interruptions. You can walk out back door and turn left and you find the toilet.
And another toilet is located at the back of the pink elevator. Once you exit the room, you'll turn right and the toilet will be on your left.
Yeah, at the back of the pink elevators, which is opposite of the canteen.
Yes. And today, our event cannot be organized if we do not have the kind sponsors.
The first one is Medtronic,
Yes, and the second is Ethicon,
Olympus,
B. Brown,
Fresenius Kabi.
and Baxter.
Yeah, please give a big round of applause for all of our sponsors. So this conference is, the origin is come from the celebration of the 20-year, right?
Yes, the 20th anniversary of Colorectal Surgery Department of Chulalongkorn University.
And we are very pleased
very
that we have every one of you here with
Yes.
us.
Thank you for travel near and far to come and join us to celebrate our 20th anniversary.
Yeah. The symposium consists of 2 days, right?
Yes, the first day will be all about lectures and debates in colorectal cancer treatments.
Yes. And the second day will be separated into 2 parts. One is the lecture that will going to be happen in this room too.
Yes, and for those who registered from the hands-on workshop for cadaveric workshop will be taken to Patiyapat building tomorrow.
Yes, tomorrow we'll have a guide for you that for delegates who have registered for the soft cadaveric workshop. Yeah, you'll not get lost. So, I think it's a perfect time to start, right? Okay. Good morning, honored guests, ladies and gentlemen. Welcome to Chulalongkorn University Colorectal Surgery Symposium 2018, and also welcome to Bangkok, Thailand. I'm Kritapha Thongrakyu.
And I am Nikrin Sitamanot. We are 6-year medical students from Chulalongkorn University, and it is our pleasure to be your MC today.
Thank you very much for joining us today. So I think every one of you and also us are so very, very excited. So let's start to celebrate the 20th anniversary of Colorectal Division, Department of Surgery, Chulalongkorn Hospital. We are going to start the first keynote lecture
With the topic, Frontiers in Colorectal Surgery, looking at the next 20 years. Please give a warm welcome to our moderator. He is the superintendent and associate professor of surgery from China Medical University Hospital, Taichung, Taiwan, Professor William Shen.
Well, a very good morning to everyone. I'll be chairing these sections for the Frontiers in Colorectal Surgery. And we're congratulated that Chulalongkorn Hospital for the 20th years of anniversary. And this lecture will be looking for the next 20 years from now. And I'll be, the speaker will be a very good friend of mine, Simon Ng, from Chinese University of Hong Kong. And Simon, I don't think he needs many of my introduction. I mean, he's assistant dean of the learning experience. I mean, he's an associate dean in the Faculty of Medicine, and he currently a professor in the Division of Colorectal Surgery in Chinese Hong Kong, Chinese University of Hong Kong. And please welcome Simon for his talk.
Thank you very much, William, for your very kind introduction, and thank you, Chi for your invitation. And really, thank you very much for allowing me to celebrate with you the 20th anniversary of Chula colorectal surgery. Now, as a friend, I'm very proud of you, of what you have achieved over the last 20 years, not just you, but your team. You have a great team because your predecessor, Professor Arun, Gerald Watt, they laid down a strong foundation, and then on top of it, you build a strong team, right? Internationally renowned. So really proud of you. I'm looking forward to more 20 years to come and to celebrating with you, okay, in the next 20 years. So now, my lecture this morning, I chose this topic. It's a Frontiers in Colorectal Surgery, looking at the next 20 years, because now we're celebrating the 20th anniversary. So I guess why not we just look forward, all right, to the next 20 years and see what will happen. This is my disclosure. Now, we are in the year 2018, but before looking forward, I guess we better, take you back to 20 years ago, all right? So now this picture was not taken 20 years ago, it was just taken 2 days ago, when the Gilsor was in Hong Kong, and then we went out for dinner, and then we had a great wine. Now we can look at this. This is La Tour, right? This is 1998, all right? Must be very expensive. Lucky it was not I paid the bill, right? It's someone else, but it's a great wine, and it's a great vintage here because in 1998, we witnessed a lot of advances, developments in techniques and technologies, and there were great evidence published in the literature. So we'll go back to 1998 first. Now this is a paper published in Archives of Surgery 1998 by Professor Bill Hild. Professor Hild is the father of TME surgery, and he actually pioneered the concept of TME back in 1977-78. And in 1998, he's actually reported his 20-year experience in TME in this paper, and they can look at his local recurrence rate of TME is just 4% at 10 years, a very, very low figure. So 1998, because of this paper, we are certain that the oncology efficacy and safety of TME was confirmed. Now, robotic surgery, I think there's 2 little pictures actually from Da Vinci. This is Da Vinci standard system, the very first generation. Da Vinci standard system was launched in 1999 and then received FDA clearance for general surgery in 2000. But in fact, the very first Da Vinci surgery was done in 1998, all right? Not in urology, not in general surgery, not in gynecology. Guess what? Cardiac surgeon, right? Very first Da Vinci robotic surgery was done in 1998. Cardiac surgery, so reported, this is from a French group. So the first robotic surgery, Da Vinci 1998. And then ESD, the very, I know yesterday you had a workshop in endoscopy, so the very first ESD, colorectal ESD was also reported. Well, was reported in 1999, but was actually done in 1998 in Japan by Dr. Garoda using IT knife, all right? Now, in 1998, Professor Angelita Habagama actually reported this very first paper. It's her experience on the impact of chemoradiation on lower rectal cancer. And in this paper, she found a significant number of patients had a complete clinical response, up to 30%, after long course CCRT. And then rectal sparing surgery was achieved in over 40% of patients who initially were thought to require an APR. So based on this work in 1998, it was published in DCR 1998, she later developed a watch and wait policy, okay? And the paper was published in 2004 in Annals. Now, besides all these, I think the most important development in colorectal surgery field was the establishment of Chula colorectal surgery, all right, 1998. This was a picture taken back in 2014 when we had the MD Anderson colorectal joint meeting. So many of us were there. William was there, Chip, everyone was there. Professor Arun was there. So it's a memorable event. So, colorectal surgery, you can see it has undergone, major evolution, all right, over the last few decades. Now, look at the treatment, MIS in rectal cancer. Now, we can divide that into early tumors and late advanced tumors. Early tumors, Sir Alan Parks actually first proposed the use of a transanal excision back in 1960s. And then in 1980s, we have EMR, 1990s, we have ESD. In 1983, Professor Gerhard Bues proposed the use of TEM, or pioneered the use of TEM in treating early rectal neoplasms. And then 2009, we have TAMIS. So we're using TAMIS right now. Now, for advanced tumor, Professor Bill Hill proposed the use of a TME, right, in late 1970s. And then we have been doing laparoscopic surgery since 1990s. 2000, we have robotic surgery. And then 2010, we have TAR-TME. So it's major evolution. But how about colorectal surgery in the next 20 years? So this is the topic 2038, right? So in the future, I cannot look that far, so I take out my crystal ball and try to look, okay, what's really inside 2038. Now, these are the three words that appeared in the crystal ball. If we look at, colorectal surgery in the next 20 years is technology, treatment de-escalation, and finally, it's personalized surgery. So I'm going to take you through all these. Now, first of all, technology, right? Now, technology, what we mean technology is actually, whether you like it or not, it's robotics, right? I guess the future, okay, whether you like it, whether you're robotic fans or not, it must be robotic surgery. But robotics is not just a surgical tool, I think, in the future. It is a platform, all right? It is a platform for us to integrate, different robotic systems together in a network, including new robotic system like the Da Vinci SP. Now, it will also act as a platform, all right, to provide data and image integration, all right? So we will see a lot of image-guided surgery in the future. So big data, obviously, okay, a lot of pre-op data, genetic data, demographic data. Because of these big data, you need to have an artificial intelligence system to incorporate within a network to help you analyze. Now we have AlphaGo, we have IBM Watson, and last but not least, I think you also need 3D printing in the future to help you to print out models for better pre-op planning. I know in Chile you use a lot of soft cadavers for pre-op planning, but in the future, I guess we can use 3D printing to print out models. So this is, in a nutshell, what I'm referring to technology in the future. Now, surgeons will worry about whether we are going to see competition in the future like automated or semi-automated robots. So we worry that we might lose our job. But in fact, last year this is already an existence. This is what we call a smart tissue autonomous robot. It's a robotic system which can actually perform suturing itself, okay, using AI. So you can see this is a robotic arm here. So it has got an AI built in, near-infrared imaging, so there will be biodegradable markers that can track 3D geometry real time. So the system can actually perform suturing itself. So they've tried to compare this autonomous robot with surgeons. They found that the suture performed by this robot was actually more consistent, all right? They said, all right, better than surgeon, of which I don't believe, actually. That's from the scientist. But I think a lot of people actually ask this question, when will AI or robotic actually exceed human performance and replace human beings? Now, this is a very interesting study conducted in 2015 by researchers from Oxford and Yale. They went to interview over 300 researchers in the field of medicine, machine learning, and also AI. And then they asked them this question, they asked them to predict whether AI would outperform humans, okay, in any activities and also the time frame. Now, this is the result of this survey. They believe that some of the activities of duty might be replaced by, AI or robot in, 10 years' time, like, driving. You see all these autonomic cars. They said Go and also retail business. In fact, Go, AI has already won in the competition, right? But how about surgery? Now, all these researchers, they believe that surgery will be taken over by AI and robots in probably 2053, all right? So about 35 years later, all right, replaced by robot. And then full automation of labor and job will occur, they believe, in 120 years, about a decade. Now, believe it or not, that's their speculation, all right? But indeed, if we look at, everything is undergoing evolution. Indeed, if we look at robotic system, right? Da Vinci system, obviously, they have undergone major evolution from the very first standard system in 1999, that's what we call Generation 1, all the way to Generation 4. Right now, we're using Da Vinci Xi, and this year we have the SP as well. All these belong to the Generation 4. Now, in the Generation 4 family, they have the da Vinci Xi, which appeared in 2014, the X system, and also the da Vinci SP. This is one of the leading innovation. It's optimized for narrow access surgery. And last year in Hong Kong, we have conducted the very first human clinical trial of using the SP system on colorectal, ENT, and urology patients. Now, da Vinci SP, I think it's, for those who haven't seen it, this is how it looks like. Quite like the XI system. It's got 3 articulating instruments, 1 articulating camera, all 6 millimeters in size, all come through a single cannula measuring 25 millimeters in diameter, 10 centimeters long. Looks very similar to an XI, but it's a single port robotic system. FDA has approved it for urologic use in May 2018, and now we're pending FDA approval for colorectal procedures. Now, this system has got, you can see, apart from a wrist, it has got an additional elbow, we call it joggle joint, and that allows triangulation when you perform single port surgery. It has got an articulated camera, and all the arms actually work very well within the volume of a tennis ball. Now, the value of da Vinci SP, I think, lies mainly in narrow access surgery, because this is the reason why they developed this robotic system. It's for transanal and transoral surgery, and even extraperitoneal surgery like hernias. It's also good in extraction surgery like colorectal surgery, where we need to make a wound for specimen extraction. So that would be the site of placement of that cannula, and urology as well. And experimentally in laboratory, we have also tried all these other routes of entry like transvaginal, transperineal, transgastric, and etc. Right? All these are experimental, but these are probably, no surgery. And I think this da Vinci SP is going to be a game changer in the next 10 to 20 years to come. Now, with this system, I have performed 22 cases of colorectal surgery, including TAMIS and even TAR-TME. All right. So this system, it's specially designed for this kind of transanal surgery. I move fast. The beauty of this is that it allows you to perform suturing very easily within a narrow lumen. All right. I use it for TAR-TME as well. And also some other experimental use, like my ENT colleagues. They have attempted to use this SP system in performing a transoral robotic thyroid surgery using the vestibular approach. The lower lip, they put in a robot and then take out the thyroid. Urology colleague, they have attempted to use this SP system in using a transperineal approach, getting the perineum, pass by the prostate and take out the whole bladder, and then they can do reconstruction just transperineally without any abdominal wound. That's in the cadaveric lab. So all these are the possibilities of da Vinci SP. But even with da Vinci SP, now I think robotics in 2018 still have some problems. Now da Vinci is still dominating. FDA approval has granted approval for SP. For ENT, we're waiting for other specialty. But the systems in 2018, they're still very bulky, all right? Like even with da Vinci Xi, very bulky, and they are not really digital yet. Although I mentioned, you want to have data, image acquisition, image-guided surgery, augmented reality, they don't exist, okay? In 2018. I think research are currently underway, and also they're still very expensive, all right? But the good news is we're seeing more competition, more systems coming to the market in the next 2 years, right? This is the Sanhand surgical robotic system, multi-port system. It's a modular-based, FDA approval in 2017. I've tried to use it. It's got a haptic feedback, but it's got eye tracking as well, but it's not really that kind of robotic surgery they would like to use, all right? Because we're very used to da Vinci. It's got clinical data. And then other med robotic flags also got FDA approval in 2017. My friend Vincent Obias in the United States have tried this on a human. It's designed for transoral and also transanal surgery. Basically, it's a robot-controlled endoscope. Okay, it can help you pass around curve. So once you reach the destination, they'll put in a laparoscopic instrument basically to operate. So it's actually not a fully robotic system. And in Korea, I think they've developed their own robotic system. It's called Revo I. It's based on da Vinci S. So they've got the Korean FDA approval in 2017 and the commercial launch in March 2018. But I spoke to them. Actually, they haven't sold any system yet in Korea. One to Yonsei, maybe, all right? I don't know. All right. And also, actually, other robotic systems are coming to the market, right? Like this Titan single-port orifice robotic technology. Looks very much similar to SP. And also the Cambridge Medical Robotics, the first-year surgical system. They have done their preclinical test. Going to have clinical tests very soon. It's a one of the smallest robotic system, also modular base, and then can maximum will be 4 to 5 arms. All right. Of course, everyone is waiting for the Verb Surgical. There's a joint venture between Google and also Johnson & Johnson. They're developing this new robotic system, not just as a robot. They call this Surgery 4.0, which is digital surgery. So it's more than a robot. They're talking about connectivity. They try to connect different systems together. They'll build in data and analysis, all right, enhanced visualization. So it's basically a whole concept, okay, which is really the future of the robotic systems and network. So I guess in robotics in 2038 will become more affordable because of all this competition, because Verb said that they have a timeline. They said the robot will appear in 2020, and many other systems, they will be ready by 2020 as well. So I think because with all these new robots, coming to the market, I think robotics will be more comfortable, more affordable. They will be smaller in size, a modular base, and they can be more versatile. Like, you can do plug and play thing. Like the Generation 4 Da Vinci, they have a very similar backbone. So it can easily, in the future, change from Xi to Da Vinci SP, just a plug and play. And definitely, I think 2038 will allow integration of advanced digital technology. So there will really be digital surgery, image-guided surgery. But whether or not there will be automation, I'm not sure. Maybe at least there will be some semi-automation. Some parts of the surgery will be done with automation, whereas some others will still require a surgeon. All right? Second part will be treatment de-escalation, okay? Now, treatment de-escalation means we do less, okay? So because there's what we call less is more. Now, because if we talk to patients about the preference of treatment of major diseases, actually no patient likes surgery, okay? They always ask, doctor, do you have just a medication to treat my disease? I actually don't want surgery, not even MIS, because there's still surgery, all right? For them, they would like to look for drugs or, some radiologic intervention or endoscopic intervention. The worst obviously will be open surgery, okay? Least desirable. Chemotherapy, high toxicity. I think MIS will be somewhere in between, right? Now, but talk about treatment de-escalation, what I mean is I think we will be doing less surgery, all right, in 10, 20 years' time. Radicality of surgery will decrease, and also surgical access trauma will also decrease. Now, why reduction in number of surgery? Now, let's take a look at colorectal, now screening, for example. Now, look at United States. They started a colorectal cancer screening program back in 1992, all right? You can look at what happened 20 years later. Incidence of colorectal cancer actually drastically decreased, and likewise, mortality also decreased. And also with better understanding of pathophysiology of colorectal cancer, like right now back home we are working on microbiota. A lot of colorectal cancer now, they are associated with depletion with a certain microbiome. So scientists are now trying to develop some probiotics to replace depleted, all right, microbiome to prevent colorectal cancer. So I think the dream of, research, the scientists, it's basically like to eradicate colorectal cancer, like gastric ulcer. They discover Helicobacter pylori, you treat them, ulcer disappeared. So maybe in the future, okay, they may be able to eradicate colorectal cancer. But that's a bad news for surgeon, right? All right? So less to do, but it's not nothing to do, right? So apart from screening, I think it's because of advances in endoscopic technology, right? Like, now we have not just a simple endoscope, but we have all the other technologies like magnifying endoscope, we have narrowband, autofluorescence, chromo, and even endomicroscopy. So I think we're seeing more and more and pick up more and more early colorectal neoplasms, not those advanced tumors, but very early. Now, many of these early colorectal neoplasms, they're actually amenable to endoscopic polypectomy. Like this is a pedunculated polyp. You can easily just, apply a snare across it and then cut it easy, right? But if you encounter something like this, big lateral spreading tumor, granular type, okay, it's quite common nowadays with all these, increase in screening, increase in endoscopic technology use. But in the past, if you see this kind of tumors, if it's located in colon, we'll subject the patient to lap colectomy. If it's a rectum, we still have a choice of doing a transanal surgery, right? But now we have a newer choice, which is endoscopic submucosal dissection, all right? Using these specific special knives, you can actually dissect along this mucosal plane and take out the whole lesion, irrespective of the size, en bloc, so you can subject that for pathologic confirmation. So it's a good technique. Back home, I've done some study comparing ESD versus lap colectomy. All right, it's an RCT, small studies. We found ECT was better than lap colectomy in terms of recovery, complication, operating time. We have also reported our experience of doing a rectal ESD compared with TEM. Again, ESD arm has got a shorter procedure time, early recovery, and a trend towards lower complications. So, ESD, it's good. It's much less minimally invasive than our minimally invasive, laparoscopic surgery. But it's technically very challenging, all right, because, we don't have, super kit in all the units, right? We don't have experienced endoscopists in a unit. So, sometimes complications like, here, perforation can occur quite easily when you do ESD. And ESD has a very long learning curve, all right? It's estimated to be over 80 cases, right? It's difficult to learn. But if we can have better tool, can we do it more easily? So now, back home, we're developing this flexible robotic system we call Master and Slave Transluminal Endoscopic Robot. Okay, with this system, even a novice endoscopist or surgeon can perform ESD easily. So what you see here is the setup. There's a prototype, very bulky, but now it has undergone certain phases of development. The newer type, it's much more smaller and also more handy. And back home in Chinese, we're also developing another flexible surgical robot. We call UHK endoscopic surgical robot like this. Gives you 5 degrees of freedom. So this system may facilitate endoluminal surgery, single-port surgery, transanal surgery, and even NOCs in the future. So much about the early colorectal neoplasms endoscopic treatment. Now, this is Angelita Harper-Gama. So she's the one who proposed the use of watch and wait. Rationale behind it, after CCRT, there will be downstaging effect. Some tumors will achieve what we call clinical or pathologic complete response, meaning no residual tumors. And we know from literature, pathologic complete response is an important prognostic factor. So the question is now, TME, although it's good, but it's associated with morbidity. And we know PCR is a good prognostic indicator after CCRT. So the question is, can we just do less invasive surgery or even omit surgery in patients with pathologic complete response after chemoradiation therapy? So this is a concept of organ preservation, right, after chemoradiation therapy. So the options include what they call watch and wait, or other terms would be deferral of surgery, non-operative management, or in selected cases, we may even do a local excision as a kind of organ preservation. Now, this is a kind of a watch and wait strategy in units, practicing this kind of approach. So basically, the most difficult part is how you actually assess your patient after CCRT for response, all right? Right now, we're doing a kind of clinical assessment, and in units doing watch and wait, they use heavily based on MRI assessment. And if MRI shows abnormality, they'll subject the patient to PET, all right? If that's normal, they will watch and wait. If not, if there's any suspicion, there will be surgery. So this is the current strategy. But as I've said, the most difficult part of the whole strategy, of course, one is the concern is resources. Second is how you actually assess the patient's response after a CCRT. So these are the modalities that we use nowadays, but many units actually using MRI. And in UK, Professor Gina Brown, she's an expert in this field, and on MRI, she says she can actually differentiate between responders and non-responders. But not all radiologists are trained in that way, and not all radiologists are Gina Brown. So they may not be able really to tell the subtle difference between responders and non-responders. So I think in this context, AI, artificial intelligence, can help. So what I suspect in the future would be something like this. Okay, we have a lot of preoperative investigation workup. You take blood, save tumors, save urine and stool. You have all the omics data, genomic, metagenomic, clinical data, right? And then you can use AI to analyze all those and predict response to chemoradiation therapy. And then you will subject your patient with rectal cancer to chemoradiation. And I expect 10 years later, you have better chemo, biologics, and even you heard this morning, immunotherapy, all right? And that can provide much better response rate. So we hope with that, we can increase the pathologic complete response rate. And after that, we'll evaluate response using all these existing, modalities, but with AI analysis to help you select, the most accurate treatment response. For responders, you can subject them to watch and wait. Near complete response may be local excision or TAMIS using robotic system. And if it's incomplete response, radical surgery, probably with a robot. So this is what I suspect, will be likely in the future. Right, probably I go through quickly. This is, surgeons, we're striving towards scarlet surgery. Benefits of scarlet surgery, I think all of you know. But right now we are doing, single port surgery as a kind of scarlet surgery. Transanal surgery is also kind of striving towards scaled surgery. And of course, nodes is still experimental, although I know there are units exploring the use of nodes in colorectal surgery. But right at this juncture, I think it's still experimental. Now, single port surgery, it's technically very challenging. Not all surgeons would like to do single port. I think initially there was a lot of enthusiasm. Right now, I think a lot of surgeons actually gave up single port surgery because it's too painful for the surgeon. So all these are the problems associated with single port surgery, a lot of clashing, difficulties in tractions in suturing. So this is what we call a hype cycle, describes the uptake of new technology. This is the single port colorectal surgery hype cycle. So it appears in the market in 2008, initially it reached a peak like this, all right? Because I think it's kind of industry driven. Everyone was fascinated, everyone would like to do single port, so it's reached a peak. But at the end of the day, right now, no one mentions about single port, in big meetings. So we reach a trough of disillusionment, right? It's because probably it's too difficult to do, and look at the literature, it only confers marginal benefit. Okay, but we don't know in the future whether we have some other tools to bring back this, what we call the slope of enlightenment, or even, not just plateau, but reach another peak in 2038, whether we can, revive this, surgical approaches. I think robotic may help, right? And Yonsei, my friend, Professor Min, is very clever, used his glove port, and doing a single port robotic surgery. But still, you can see this is a Da Vinci SI system, is still bulky. There are a lot of clashing, limited space for bedside assistant. Even with the Da Vinci single-site surgical system, which is designed for single-site surgery, again, it's still bulky, and there's no endorace and no third arm. So now, here comes SP. Now, SP is not just for transanal, it's also designed for single-port surgery, all right? So this is an operative photo showing you back home. This is a setup when we do a Da Vinci SP right hemicolectomy. So we put in a single port, and exteriorize the colon after mobilization, do anastomosis. So you can see this is an end cosmetic result. What you need is just a very small transumbilical incision with this SP system. So this is a short clip showing you how we perform right hemicolectomy with the SP. And this is a laparoscopic view of the same operation, right? This is how it looks like, how it works inside the peritoneal cavity. Because of time, I think I need to move on. We also use SP in doing a low anterior section. Transanal TME, I think, is a very hot topic. I think many surgeons now are doing that. I think in the afternoon, I think we're going to have a debate sessions on transanal TME. This can be regarded as a bridge to nodes. And now, how about pure nodes transanal TME? Is it feasible? Because right now, transanal TME, we're doing a hybrid, using a hybrid approach. So we're laparoscopic mobilization and then transanal dissection. But how about whether we can do a pure nodes? Actually, if you look at the literature, Professor Laurent from France actually has used this TEO long version in accomplishing a pure nodes transanal TME. But I think with emerging robotic platforms, coming in the next few years and even up to 2030, I think pure nodes transanal TME, it's feasible. So we can see all these, new gadgets will be coming into the market. So with SP as well, all right? So I probably skip that. So it's final few slides about my thoughts about personalized surgery. You heard about personalized medicine, but I think there's also something called personalized surgery. By personalized surgeries, I mean we're talking about right patient, who to operate, right treatment, that is how, and right timing, that is when, all right? So because right now, if you see a cancer patients in your clinic, they are just, they have got, particular information. But if you look at the literature and look at guidelines, there's just too much data to handle, right? You have ESMO guideline, NCCN, Japan, NICE. I don't know whether Thailand, you've got your own guidelines. Just too many guidelines to choose, okay? How can we decide? How can we decide the best choice for your patient? So here comes AI. So this is really, in practice, IBM, Watson, oncology, they're using the AI system to help physicians to make a good decision. All right? And how to choose between a different approach. Say, for example, if you have an obese patient, right? Low rectal cancer, narrow pelvis, big prostate. Now, the argument is always, we go to meetings, they're debating whether you should do a top-down TME or bottoms-up TME, all right? To complicate the issues now, to put in the equation, we've got lab and robotic as well. So you can see there are many combinations, right? You can do a lab or robotic top-down or lab or robotic bottoms-up, all right? How to choose, all right? Maybe in the future, AI can also help you, okay? You fit in all the information, patient's preference, everything. AI can help you decide, all right? Back home, we are developing this AI system, okay, when we do colonoscopy to help us recognize polyp, all right? When we do colonoscopy, that may be missed by endoscopists. And we're developing further, hoping that AI, after, machine learning, can help us characterize the polyp and help us differentiate between, really non-neoplastic and neoplastic polyp, all right? And this I've shown you, right? So final personalized surgeries, right patient is, we make use of big data, all the pre-op data, omics data, and then your AI help you select the right patient for the right treatment, whether you subject your patient to neoadjuvant, endoluminal surgery, or radical surgery, and finally, right timing, whether you can defer your surgery, all right? So that's personalized surgery. So in summary, so these are the three points that I've covered: technology, treatment, de-escalation, personalized surgery, and that's my thoughts about surgeries in 2038. So in conclusion, I would like to say that robotic surgery will play a more important role and has a wide applications in the future in the next 20 years. So, and emerging robotic platforms will enhance, I think, single-port surgery, endoluminal surgery, and even nose development. Now, AI, artificial intelligence, for sure will facilitate the diagnosis of diseases, help select the most appropriate treatment for patients, so that's what I call personalized surgery, and even assist surgeons in future robotic surgery, all right. So I think this is very important. I think we can still keep our jobs in 2038, but 2050, I don't know. So maybe your next 20th anniversary, the next, maybe we'll all lose our job. Okay, with that, I would like to end my presentation. Thank you very much. And just a small advertisement. In Hong Kong, January 2019, January 19 to 20 in Hong Kong, our society, Hong Kong Coloproctology, will be hosting this International Colorectal Disease Symposium. Many of you have already been invited as a faculty, so I do hope to see you in Hong Kong in January. Thank you very much.
Thank you very much, Simon. Because it's a keynote lecture, so we will not have any